Good evening, doctors, and warm welcome to today's ECME on multiple myeloma. I am Dr. Devang Sarveya from CIPLA Oncology team. It gives me immense pleasure to welcome our distinguished speaker for the day, Dr. Chirag Shah, who is Diplomat American Board of Hematology and Medical Oncology, who is working as a Director, Department of Hemat-Oncology at Apollo CBC Cancer Center at Ahmedabad. Welcome, sir. He's going to take us through a very important topic on multiple myeloma, where he's going to discuss on the topic of multiple myeloma, diagnosis, and the treatment paradigm. So with that short note, I would like to welcome Dr. Chirag Shah to take it over and start with the presentation. Over to you, sir.
Thank you, Devang. Good evening, my doctor colleagues. Let me start sharing my screen. So, last time we spoke about lymphoma, and the second important blood cancer category that we are going to talk about today is multiple myeloma. These are some of the points I thought were most important highlights. Is that one is when to suspect myeloma. Of course, we'll talk about how to make diagnosis and treatment. But probably, if the take-home message that I would like everyone is to understand when to suspect it and to share our excitement in the improvement in the survival. That when I started my practice 20 years ago, average myeloma patients were surviving here about 1 year, 1.5 years. And when somebody crossed 2 years, everybody was very happy that, wow, this is a great achievement kind of thing. And that this is something to, not so commonly heard of, and everybody spoke about it, that myeloma patient is living longer. And 2003, we had bortezomib, and then further multiple drugs. The transplant became feasible in India more often, and then more drugs. Now the survival is average 5 years, and this is average, means a lot of our patients have crossed 10 years. This is a huge improvement. So, unlike what most people think of cancers, many cancers now have such improvements, and myeloma is certainly one of those big ones. And this comes with excellent quality of life. So that's another thing that I want you to take home, is that all this is not at the cost of quality of life. If you know of these patients, they are at work, they are doing everything at home, they are not on any medicine for many years. So even though multiple myeloma is technically an incurable illness, the term we use now is operational cure. Means a lot of these people are doing so well and they are not on any medicine, so practically it is like a cure. To give you one example, my first myeloma transplant patient, that is now about 11 years, 12 years out, after the transplant, he was on some medicine for probably 6 months. Since then, he is not on any medicine. and initially came regularly for follow-up. Now he comes to follow up whenever he wishes. So, old patient doing well, and he's running his shop, absolutely normal person, with hardly, once a year maybe doing blood tests. So all these are now possible with myeloma. With this background, let's first talk about few cases. Uh, so when to suspect myeloma? So this is a 55-year-old man with no symptoms. His hemoglobin is 10.5 on routine CBC. Other counts are normal. What is the general advice given by a family doctor or MD physician to such patient? Iron and vitamin supplement, follow up after 1 month, don't worry. Now, this is what happened to this patient. His blood smear at that time when hemoglobin was 10.5 on the routine CBC had this rouleau formation, which you can see here. There is rouleau formation. This is due to the very high protein levels. He comes after some time when, in fact, unfortunately, his kidney is bad, his creatinine is high. The kidney biopsy shows this kind of cast, the renal cast, and his bone marrow showed increase in the number of plasma cells. These are all plasma cells, very high number of plasma cells in his bone marrow. So at that time when he presented, in fact, if more investigation could have been done, then he would not have ended up with all these issues, and he would have actually been diagnosed with myeloma at very early stage when he was asymptomatic. This is a 34-year-old man with history of mild backache, hemoglobin 11 and ESR 60, and X-ray spine showing mild osteopenia. And he is advised to take ibuprofen, paracetamol, and follow up as needed. After 2 months, he is now in stretcher, unable to walk. In fact, even turning in the bed is extremely painful. And he has severe back pain, has pedal edema, and his X-ray spine is now showing compression fracture of D11, 12, and severe osteopenia. His creatinine is 2.2, potassium is 6.0, hemoglobin 8, and ESR 150. So, when do you suspect myeloma? So, first is the most common form of presentation is anemia, and even if it is mild, it can be a sign of myeloma. So, it doesn't have to be a severe anemia. High ESR is an important sign in a patient who is otherwise healthy. He is not running fevers, and he comes to you in OPD and has a high ESR, that's a suspicion. Peripheral smear may or may not report rouleau formation, and creatinine may or may not be high. But anemia patient is an important sign to think of myeloma. Now, if you look at the report of CBC, you can see in more detail that if the MCV is low, you think of iron deficiency first and you do the workup accordingly. If MCV is very high, you think of B12 deficiency. But if MCV is normal, that is a more difficult case, and that is where you have to do more investigations, think of this, check ESR, and consider myeloma. The another very common patient in practice is back pain. Again, you can't investigate every back pain patient for myeloma. So you should do the minimum testing, that is, any patient with back pain should get a CBC, creatinine, ESR. Now, if ESR is high or creatinine is high, that is a red flag and absolutely important to make sure this patient has a diagnosis of whatever underlying is going on. In fact, when you talk to the radiologist, you realize that so many of patients of back pain, they do MRI, are diagnosed with metastatic cancers. So anyone with back pain and abnormal blood tests such as low hemoglobin, high ESR or high creatinine, it is important to do additional workup. Now, if X-ray is showing lytic lesions or osteoporosis or compression fracture, that is even more significant sign that you need to look into that. But even with X-ray being normal, if there are other signs like anemia, high ESR or high creatinine, either one of the three, you should investigate further. If a patient comes with high creatinine, now it doesn't have to be very high. See, if your patient with a long-standing, say, diabetes, hypertension, his creatinine has always been about 0.6, 0.8, and now it is 1.5, then something has happened. It could be anything, including myeloma, and that requires additional workup. You cannot just label it as it is because of diabetes or hypertension. So the simplest things are, you check for the urine. If there is significant proteinuria, then there is suspicion something else is there. It is not a simple diabetic nephropathy or hypertensive nephropathy. If the patient has low hemoglobin, more suspicion, high ESR, back pain, everything adds to the suspicion level. Some people would undergo a renal biopsy, and if there is a cast nephropathy, then again there is a suspicion for myeloma. The routine serum electrophoresis and immune electrophoresis may miss about 20% cases of multiple myeloma, because the free light chain related myeloma will be picked up only by FLC assay, the free light chain assay. So especially in renal failure, this is an important consideration. Now, once you have a suspicion, the next step is to send them to a specialist or the laboratory who are used to doing this kind of workup. In many places, the pathologist would advise what tests to do, and they would initiate the workup. The commonly done initial tests would be protein electrophoresis, immune fixation electrophoresis, and FLC assay. Additionally, you look for calcium level and bone lesions by using skeletal survey. You can do quantitative immunoglobulin levels, but ultimately we do need bone marrow biopsy to show there is increased number of plasma cells, and they can be characterized as monoclonal by use of immunohistochemistry if required, especially if the number is smaller, then IHC becomes more important, or if there is a concern for additional diagnosis. The features, so when we have increased plasma cells in the bone marrow and monoclonal protein is increased, by itself, it does not make it multiple myeloma. It may still be what we call smoldering myeloma, or in very early cases, a monoclonal gammopathy of uncertain significance, or MGUS. So what makes it myeloma is this sign of end organ damage. And the short form for this end organ damage is CRAB. So if there is high calcium, abnormal creatinine, low GFR, low hemoglobin, or bone lesions on skeletal survey, the X-rays or MRI or a PET-CT scan, then we can label it as multiple myeloma. We discussed earlier the free light chain assay, and this is an important advance in the field of myeloma, where we, as we discussed, that 20% of cases of renal insufficiency in myeloma can be missed by other tests, and this is a very sensitive test, and also it provides a very good assessment of response because the half-life is very short. So we can do the evaluation after the treatment in a matter of weeks to see if there is improvement. And because of this test, we don't need to do cumbersome 24-hour urine collections anymore. Now, the Indian perspective, we saw, if you remember, our second patient was only 34 years old. So the median age in US is 65 to 75 years, and the textbooks always mention this is a disease of elderly. But here in India, we see a lot of young people. 55 is the median age for us, and we have a lot of people who are in their 40s and some, quite a few in their 30s also. So when you see the signs that we mentioned, when to suspect myeloma, and if the patient's age is not so high, then don't discount myeloma thinking it is a disease of old people. In India, especially, it is important to suspect that even in younger age group. And the numbers are seemingly on a rise along with other cancers. 2015, the total number was about 17,900, and 2020 expected 21,000. So this is no longer a small number. And as we've seen earlier, that if you suspect early, then you can prevent people from going into renal failure, bone fractures, and severe pain. And the results are now excellent. The quality of life is excellent. So it is important to make early diagnosis and treat well. For prognostication, we do beta-2 microglobulin and albumin. Using what is known as the ISS staging, we put the people into 3 stages. Additionally, later on, cytogenetics, especially by FISH panel, was added, and LDH. These 2 tests have further refined the prognosis in myeloma. In addition to this, the time to complete remission once we start treatment and the type of treatment also have a bearing on the prognosis. So what are the treatment options that we have? The first is chemotherapy. Second, the stem cell transplant or bone marrow transplant, the newer medicines, and then supportive care. How do we start approaching a multiple myeloma? If you look at any of the guidelines, any of the treatment related articles, this would be the starting point. That a newly diagnosed multiple myeloma, whether patient is transplant eligible or ineligible. That what this tells you is that practically in every patient, transplant should be considered. Unlike a acute leukemia, where we are used to thinking that transplant is for patients who have only bad risk or who have relapse. In myeloma, it is very different, and that here transplant is a consideration for practically every patient, including stage 1, 2, 3, standard risk, medium risk, high risk, everybody. So if patient is eligible, that means patient is physically fit enough to go for transplant. Then there is few months, about 3 months of induction treatment, followed by transplant, and then some maintenance with some medicines. If for medical reasons patient is ineligible for transplant, such as very elderly, age more than 70, or has low ejection fraction, these are or very frail, very weak patient. These are some of the patients who are ineligible. Otherwise, practically anybody below the age of 70, you can say, is eligible unless proven otherwise for transplant. This includes patients who have diabetes, hypertension, have had stent placed for coronary artery disease, and even those with renal failure. The patients with renal failure, high creatinine, say creatinine clearance of 30, 40, 20, they are also eligible for transplant. They need some extra care and some reduction in doses, but they are still eligible for transplant. So the transplant here is autologous. That means you are using patient's own cells, and there is no need to find a donor. So that way, this transplant is much less riskier in terms of the typical transplant complications. And the follow-up is also much shorter. Transplant provides an excellent treatment-free interval. Patients can, after transplant, many of the patients are can be off treatment for 5 years, 7 years, and some even go more than 10 years. The source of the stem cell now is generally peripheral blood almost always. And that is why instead of the bone marrow transplant, the word came stem cell transplant or hematopoietic stem cell transplant. As we earlier discussed the concept of operational cure, imagine patient who has been treated and now 5 years, 10 years, he is not on any treatment. It's a practically a cure. Allogeneic transplant is very rarely done. The results still are very poor, with about 30 to 40% of patients dying from transplant in multiple myeloma with allogeneic transplant using somebody else's stem cells. That is why it is extremely rarely done. On the other hand, the autologous transplant, the risk is only 2%. Mortality risk is only 2%, means 98% people would very safely be discharged. When I started practice in 2002, the number of medicines we had was only melphalan, prednisone, VAD, vincristine, adriamycin, doxorubicin, which required putting a central line and continuous infusion for 4 days. This I have not done now for I think 12-15 years, a very old treatment and very cumbersome for patient and with results not so great. Then there was dexamethasone and cyclophosphamide. Now we have 18 options approved and many more combinations, which may include 2 drug, 3 drug, 4, or occasionally even 5 drug combinations. So imagine these 18 options with multiple combinations possible. That's many options to treat. This includes mainly the so-called IMIDs, the immune modulators, thalidomide, lenalidomide, and the latest pomalidomide. Dexamethasone, prednisone, the both steroids, and then bortezomib, carfilzomib, ixazomib. These are the injectable options. Exazomib is oral. Uh, Daratumumab is a monoclonal antibody. These both are monoclonal antibodies. These are the old chemotherapy options: liposomal doxorubicin, vincristine, cyclophosphamide, bendamustine, a newer option, again, but a chemotherapy, and melphalan. And these are some of the very new options not available in India: selinexor and anti-BCMA antibodies as well. So as I said, that so many combinations are possible. This is the international guidelines known as NCCN, most widely used guidelines, and they have so many combinations listed out. The most commonly used is bortezomib, lenalidomide, dexamethasone combination, which is the number one combination used in patients who are candidates for transplant. And those who have relapsed, there are again many options, and the way we choose among these options is based on several factors. We look at what was done previously, how long the response lasted, what are the patient's medical conditions, the cost, logistics. If patients are living far away, coming from a different far away town, then we choose different options which are more convenient. In patients who have had a long treatment-free interval after first transplant, a second transplant can also be done. And if they did not have a transplant first time, then second time when they have relapsed, a transplant should be done. The supportive therapy is also very important in myeloma, and that includes the bone-related treatment to reduce the risk of fracture. As we have seen earlier, that myeloma is a disease which can cause fractures in either the spine or the long bones. To reduce that risk, bisphosphonates such as zoledronate are widely used. Denosumab is another option. This is the most widely used, but it cannot be given in patients with significant low GFR. So if patient's kidney is not good, then you can give denosumab instead, which does not have that contraindication. Anemia can be treated by erythropoietin, although majority of patients controlling myeloma itself improves the anemia very quickly. Some patients with repeated infections need IV immunoglobulin, very uncommonly used now. For pain, morphine or other medicines, radiotherapy for extreme pain. However, I would caution that radiation should be very sparingly used and should be avoided as far as possible for treating pain in the myeloma in early cases, because once you radiate the spine, whatever area, spine or pelvis or any other area, the bone marrow in that area is not going to survive and for many years. So if patient gets radiation in larger areas, then you are reducing their bone marrow reserve. That means they may not be able to undergo autologous bone marrow transplant in the future, or even the ability to treat them with standard medicine may be compromised, because if they have myelosuppression, then we would not be able to use many of the medicines. So please avoid radiation. Nowadays, the other medicines for pain, treating myeloma well, is itself an extremely good pain measure, and along with morphine and various medicines, even extreme pain can be managed very well. Most of the patients who come in stretcher, who cannot even turn in the bed because of pain, can be controlled very well with morphine. And once you start them on treatments like bortezomib, dexamethasone, lenalidomide, pomalidomide, etc., within 1 or 2 weeks, their pain is extremely well controlled, and in about 2 weeks, they are able to start walking with walker, and in about 4 weeks, they generally are able to walk completely independently. For the kidney part, maintain adequate hydration, avoid NSAIDs like ibuprofen, diclofenac, etc., and treat hypercalcemia, which is an important contributor to renal failure in some patients. So in summary, it is very important to suspect myeloma in case of anemia, back pain, renal failure, and occasionally patients may present with neuropathy, which is a presenting feature of myeloma in some patients. Some patients with amyloidosis may present with neuropathy or low ejection fraction or other features of amyloidosis. Prognosis is extremely better now, and in fact, the survival for most patients is over 5 years, and many patients now can live over 10 years. In the Western large cancer centers in US or Europe, in more than 10 years is almost a normal thing, except the high risk cytogenetics, which is only 20% of people. So that means in 80% of cases, now our expectation is actually more than 10 years if patients are able to undergo the standard treatment, and that includes the what options we have shown earlier, which includes steroid, bortezomib or similar treatment, lenalidomide or similar group treatment, and autologous stem cell transplant. And all this comes with excellent quality of life. The drugs are also much cheaper now. All the common drugs that we use in myeloma have Indian generic options, so the cost is so much less now. The transplant cost in a private corporate hospital is in the range of about 6 to 7 lakhs, and some even do at 4 lakh. It is covered under Ayushman Yojana and other government schemes and other reimbursement schemes by corporates, etc. And the various government hospitals, it is at even lower cost. So please don't think that myeloma treatment is expensive now. It is certainly manageable and provides a very good prognosis. And if we don't diagnose in time, then person can go into complete renal failure and stage renal failure with a dialysis dependency, and those patients, the quality of life is very poor, and treatment with complete renal failure is very difficult. So they generally then don't survive too long, about 1 or 2 years. So please make sure that people don't go into ARF from myeloma. Of course, they can develop severe fractures, sepsis from the low immunoglobulins, and can die from the sepsis in myeloma. So late diagnosis has some serious consequences, including life-threatening. Thank you.
Thank you so much, Dr. Chirag, for that wonderful presentation and taking us through the details of the diagnosis, the early how to suspect, when to suspect, with the case studies and description and the changing paradigm in terms of survival that the medical sciences progress through, right from being earlier survivor was 1.5 years and now up to 5 years and even more up to 10 years. So that's really very incredible thing that has happened in terms of multiple myeloma. Sir, we have certain questions. Most of them were covered in your slides, I'm sure, and we'll take you through few questions, sir. Sir, people are asking, what can be myeloma be mistaken for? Is there any other disease that can be mistaken for with the myeloma?
Right. So somebody has, say, anemia, and anemic patients may complain of low-grade fever. So even though if you measure, there will be no fever, but they may say that, I get feverish more so in the evening. Now, in India, frequently low-grade fever, anemia, high ESR, TB comes to mind for many people. And so that is one thing.
Right, sir.
The other is that, of course, if anemia is treated like a nutritional anemia, which is another thing what most people do, that still today many people don't look at the MCV and
Yes.
they look at anemia, they say, oh, you look otherwise well, so your hemoglobin must not be a serious issue. And so they write multivitamins and iron supplements. So not to, make a diagnosis of anemia that way. Like I mentioned earlier, if the MCV is significantly low, then think of iron deficiency and do the workup for the same. Or if you feel the patient is very reliable for follow-up, then maybe you can give them some iron supplement without further treatment, further evaluation. However, one caution is that in male with iron deficiency anemia, low MCV anemia, above the age of 40 years, and postmenopausal women with low MCV anemia, means iron deficiency anemia, it is extremely important to rule out blood loss. And this could be many times a malignancy, GI blood loss from a malignancy. So even there, empiric treatment may not be a good thing to do. So I would say that these are the two most important things. Then collagen vascular disease, lupus, etc., rheumatoid arthritis, they would also have high ESR, anemia, and normal MCV. So they can also be taken, and you may miss myeloma. Apart from anemia, we mentioned that very common is the diabetic nephropathy. So you have a long-standing patient in your practice with diabetes of say 10 years or hypertension of 10 years. Now his creatinine goes up. The first thing you think is that the patient has developed diabetic nephropathy. And so you don't investigate. But it is very important that, at the time when the creatinine goes up first time, in the routine follow-up patient, the proper diagnosis should be made to make sure that you don't miss any other reason. It doesn't have to be myeloma all the time, but there may be other reasons also. So I would say that those are the common things.
What could be the investigations done at that time for the diabetic nephropathy patient with high creatinine?
So first is the urine routine. If there is proteinuria, high, especially 3+ or so, that's a very strong suspicion that something else is going on. And a free light chain assay can be done if there is a suspicion, or if it doesn't seem everything right, there is new anemia also, high ESR. Any of these are all little red flags. They're telling you that this is not the routine diabetic nephropathy. And in such a case, you are better off referring the patient to nephrologist to make sure that nothing else is being missed. And of course, the third is the back pain, where simple osteopenia can be mistaken as age-related osteoporosis, and you may not suspect myeloma. So it is important to keep a high suspicion in a patient with back pain and osteopenia. If the patient is not above the age of 60 or 70, then osteopenia anyway should be a concern. And combine that with low hemoglobin or high ESR or high creatinine, you should be able to strongly suspect that this is not the typical routine back pain, the musculoskeletal one. There's something else is going on.
Right, sir. Sir, another question from audience is, what is the major complication if the patients are diagnosed with multiple myeloma? And what are the watchful signs and symptoms that can be seen by the physicians?
So, you mean those who are already diagnosed and undergoing treatment?
Sir, it can be both ways, one who are already diagnosed and one who are yet to be diagnosed.
Okay. So for the yet to be diagnosed, I think what I've just alluded to is that, if there is anemia and if there are any of these other signs, then you have to be careful.
Right, sir.
Or say you have now started treatment with iron and vitamin. Patient comes in follow-up after 1 month or 2 months and the hemoglobin is not improved. Okay.
Right.
That's some time when you should, do a little more investigation or think about something else. Look at MCV. The physicians must get into the habit of looking at MCV. That is why the laboratory is giving all the indices. So if the MCV is in the normal range, then this is not a typical nutritional anemia and you have to think of other things.
Right.
And yes, of course, apart from anemia, if patient is complaining of back pain or in spite of supplementation, the hemoglobin is actually going down, those are the signs. Unfortunately, myeloma until late will not give you very big signs that you can catch.
Right.
These are all subtle signs, sort of. It's like patient will not have very dramatic symptoms.
Yes.
Renal failure until the very late, a patient will have no edema, no hypertension, no tiredness, he'll be fine. It develops only when it is all and very bad renal failure. Similarly, back pain may not be extremely bad. So you have to be, looking out for these things.
Right. Sir, from the patient per se, what can a patient do to look out for in their day-to-day life? Do they need to do some exercises, some practice on the foods, or some kind of safety that they can, be precautionary about?
You mean prevention of myeloma?
Yes, sir. The prevention space.
So we don't know the etiology of myeloma. That is why we normally don't talk about it in our presentations.
Right, sir.
Unlike, say, breast cancer, here we don't talk about causes. Right. Although I would say that since you have asked the question, there is some early data showing that multiple myeloma has some link with reduced physical activity.
Okay.
So, low physical activity we know has been linked with many other cancers, but we never typically think of them associated with blood cancer. We always say it is, breast cancer, colon, prostate, the lifestyle associated cancers. Right. But myeloma also is potentially associated with that. Other than that, it is not associated with any foods or anything else that we know of. And this is also a preliminary thing. So no specific advice on how to, prevent myeloma other than what is mentioned for every other, cancers. The same lifestyle modifications will help you here also.
Right, sir. And sir, in which category of patients do you recommend transplantation in multiple myeloma? And how long can a person live with multiple myeloma without treatment, sir?
Okay. So There are two questions. One, you mentioned who should go for transplant.
Yes, sir. So percentage of patients who can go for transplant and percent who are not eligible, or maybe we can put it as like percentage of patients on chemotherapy versus the transplant.
So percentage of patients who are candidates for transplant are practically everybody. Unlike other cancers, those who are not candidates are those above the age of 70 or those who are very weak. When I say very weak means they are bound to wheelchair or bed bound.
Right, sir.
Then patients who have low ejection fraction from whatever different reason, but if their ejection fraction is below 40%, they are not good candidates for transplant. So other than that, almost everybody is a candidate for autologous transplant in multiple myeloma, and it is a part of initial treatment. So unlike the other cancers, blood cancers, this is to be done upfront. Only you give 2 to 3 months or maybe 4 months of treatment, reduce the disease bulk to a great extent, and then immediately transplant. Right. So you can say that about, in India, about 80% of patients who come with myeloma are actually eligible for transplant.
Right, sir.
Patients don't need hospitalization. That is a very important thing for the other treatment, the other than transplant, what we do before transplant, after transplant. Only during transplant, there is about 3 weeks of hospital stay.
Okay, sir.
Rest everything is now outpatient. In fact, it is so easy now that the most common treatment which is used is bortezomib injection, which is a subcutaneous injection, so not even intravenous. And the others are oral. The lenalidomide, pomalidomide, and dexamethasone are oral. So this is a very, very convenient treatment. In relapse patients, we have some intravenous options. But even there, we have many oral options and subcutaneous treatment. So this is, you can say, a fairly home-based therapy.
Home-based therapy.
You asked without treatment.
Survival
Without
rates.
treatment, survival will be very low, very short, because either from renal failure or from low immunoglobulin, patient can develop very bad infection, or the hemoglobin can go down very low and go to a life-threatening level. Myeloma, some patients have a very slow course. So some doctor may have seen patients who survived without treatment for 6 months or 1 year, or without diagnosis even 6 months or 1 year. But those are very uncommon, having such an indolent disease. So this is not something where we can follow without treatment. Unlike in lymphoma, for example, we mentioned last time that a follicular lymphoma patient can be managed without treatment for a long time. This is not the case with myeloma.
Right, sir. And sir, is there any treatment required for MGUS or SMM myeloma?
Okay. So,
and what
right.
can be the treatment?
Okay. So MGUS is a different thing. It is not a myeloma. When we mentioned earlier that we have three, you can say three different diseases, but a continuation. So we have MGUS.
Yes.
Then we have smoldering myeloma, and then we have myeloma. So kind of MGUS progresses to smoldering over time, and then it progresses to myeloma over time. So MGUS does not require treatment, but only monitoring.
Okay.
Smoldering also does not require treatment. However, now there is some data that among the smoldering, there are high risk and low risk.
Yes.
So the high risk smoldering, there is a potential for doing oral treatment with lenalidomide. But in general, you can say that they also don't need treatment, and they are. We have patients with MGUS on follow-up for 10 years. no treatment.
Right, sir. And how fast is the progression from MGUS to smoldering and from smoldering to multiple myeloma?
Good question. So MGUS, the sort of a general statistic number is that 1% per year, means out of 100 MGUS, 1% per year will develop myeloma. So by 20 years, about 20 people would have developed myeloma. In other words, even at 20 years, 80 people would still be disease-free and not require any treatment. That number with smoldering is higher, and you can say maybe 5% per year. Very general number to give,
Okay, sir.
but significantly higher than
The MGUS. Yes, sir. And sir, your thoughts on the recent advancements like HDAC inhibitors, CAR-T therapy, anti-BCMA antibodies, and where do you see it coming up in India, and how soon or we can expect that treatment options?
So, the out of the newer options, first I think we should say, apart from what we mentioned, daratumumab, the monoclonal antibody, which is available in India and has lot of scope, and it is an important part of the myeloma treatment. As of now, it is fairly expensive. So it is limited to certain settings and certain financial, section. But if possible, that is an important drug. What you have asked for are the anti-BCMA and CAR-T is going to take some time to come. The anti-BCMA currently is about 30 lakhs per dose. So it is very expensive. And CAR-T therapy is about 5 crores.
Okay.
5 CR.
Yeah.
So until a very suitable Indian option is developed, or the technology changes and it becomes much less costly to make these cells, then it is going to be very expensive still, and a far future for India, at least I think 5 years.
Yeah, and so your conviction on them, like as per the treatment, if they are very well placed, or how is it like? Or the conventional ones are also okay to manage?
No, the conventional treatments for myeloma are still very good, because as we said, 80% of people who are not high risk, they do very well with the conventional options.
Right, sir.
It is the high risk cytogenetics people who have difficulty, and there will be a role for them. But again, for myeloma, still CAR-T is very early. The approval is very recent.
Right, sir.
So unlike for acute lymphoid leukemia, it is still very new in myeloma.
Right, sir. Sir, coming to SREs that you see in multiple myeloma patients, is it very frequently seen? And sir, how do you prevent them, or what are the treatment options that you use, sir?
Right. So SRE means skeletal related events, that is fracture or severe debilitating pain. That's a fairly common scenario. Obvious fracture is now much less common after good treatments. And the prevention is by telling the patients, one, not to lift weight. And it has to be emphasized again and again, because some simple acts, what we do in our day-to-day life, people would not count them as lifting weight. For example, a bucket full of water.
Yes, sir.
So in bathroom, if you pick up a bucket full of water, it is 20 kg.
Yes, sir.
20, 30 kg. Or lifting your grandson or granddaughter.
Yes.
So that is, you don't realize that as a weight lifting.
Yes.
So you to advise patients that don't do these things and be careful. Then the other important concern in India is falls from the uneven surfaces, slippery bathrooms,
Right, sir.
and two-wheelers fall from two-wheelers, or even the driving two-wheeler is also taking a lot of weight, because when you stop or if there is a sudden jerk, and then whole weight comes on your hand and leg.
Okay. Yes.
So driving two-wheeler can actually lead to a risk of fracture with multiple myeloma patients. So those are important things. The medicine part we have mentioned already, which is zoledronate, which is to be given every 3 months. Earlier we gave every 1 month, but the latest research shows that every 3 months is equally effective. And for those where there is renal failure, denosumab is an excellent option.
Sir, and sir, how is the dosing for the denosumab? Is it once per?
It is once a month.
Once a month, right, sir?
Right.
Okay, sir.
So that can also be done every 3 months, but the original studies for that is once a month.
Sir, and is there any therapeutic
There
difference?
is some question I see in the chat box.
Yeah, yes, sir. What environment to create after coming home from chemotherapy, and what to expect during that period? How much time does it take to recover from chemo weakness?
So myeloma chemotherapy, what we mentioned, the most common option, bortezomib, lenalidomide, and dexamethasone combination, is actually, it does not make people very weak, unlike the typical IV chemotherapy that we are used to thinking. There is no hair loss from these options. So most of the myeloma treatments don't cause hair loss, except the very few old ones.
Right, sir.
And transplant, where high dose melphalan is given. So we say that a person can continue to work through this, and there is no need to reduce activity if you are not feeling very tired. So if you are tired, then yes, take adequate rest, because it is important to make sure that you reserve energy for healing, for treatment, but no specific timetable that you must rest for, say, 3 months or 2 months, like that. And some people may have difficulty with steroid, because this is a high doses of dexamethasone, and then your doctor will advise accordingly what you need to do in individual case. Elderly people sometimes have significant difficulty tolerating these high doses of steroids, which is a part of myeloma. Diabetic patients may have issue, but that is very manageable. And now we don't reduce doses for diabetes. The diabetes drugs and insulin are very good and can control the diabetes very well during that time period. So it is important to focus on the myeloma rather than worry about diabetes.
Sir, any thoughts on what should be the diagnostic workup done by a physician before referring it, and the right time of referral by a physician?
So I would say that if you suspect a myeloma, then you can order serum protein electrophoresis, which is not expensive also. And at the same time, in about 70-80% of cases, it would be useful to diagnose. The other tests you already mentioned, the ESR, creatinine. You can do also skeletal survey, that means x-rays of spine, shoulders, hips, pelvis. So you cover all the major bones, and the skull. So if there are any lytic lesions, these can be done by physician. Bone marrow can be done in certain people who are doing it. However, I would in general recommend not to do that, because there are newer tests that we would like to order from bone marrow, which are important in the treatment planning and follow-up. And so if the bone marrow is done beforehand and those samples are not sent, most patients are very, very reluctant for a repeat bone marrow biopsy, and which we can understand. So not to put through the patient for 2 bone marrow biopsies. So better to avoid that test.
And sir, any awareness drives that for the patients, you some important message to the patients from your side, sir?
So yes, for the patient that myeloma has excellent results now. The treatment is very well tolerable and very affordable, and great survival, great quality of life is possible.
And sir, last take-home message for our audience from your end, sir, before we close the session.
Be positive about myeloma. When you get a myeloma patient, tell him that him or her that this is a cancer where a lot can be done, so not to worry.
So, sir, thank you so much from the entire Cipla Oncology team for the wonderful presentation and a great interactive Q&A session with elucidating on all the aspects of about the transplantation, the treatment, the diagnosis, the physician's referral part, patient awareness, and all this part. And really thankful to you, sir, for spending this time on Saturday evening for this educational activity. And we look forward to many such meaningful events in the future, and look forward to have you, sir, on board for such meaningful events, sir.